I'm your host, Dorothy. Welcome to Egg Donation Friends webinar number 10. Today's topic is recurrent and spontaneous miscarriages. Are donor eggs a cure? Today's presenter is Dr. Juan Carlos Castillo, a specialist gynecologist from Instituto Bernabeu in Spain. His presentation will last about 25-30 minutes, then the Q&A session will follow. If you want to ask a question, please click on the gray question mark button and type your question. If you want to type a comment, please do not mark it as a question. All the medical questions will be answered by Dr. Castillo after the presentation. All other questions related to the clinic's offer or logistics will be answered by Raquel Gallego, the patient coordinator. Our webinar is being recorded and you will be able to view it on our website. We will also publish transcript with all the questions and answers. Just to confirm, can you hear me well? This is the question to our attendees. Is the sound okay? Yes, fantastic. Dr. Castillo, good evening.
Good evening, Dorothy.
Fantastic. We have a very nice connection. Yes, I think we can start. If you're
Perfect,
ready.
thank you so much. I'm very ready to go. Well, first of all, I would like to thank eggdonationfriends.com for inviting me to give this lecture about this topic, recurring miscarriage, recurring pregnancy loss, and spontaneous miscarriages. Are donor eggs a cure? And the idea is to give you some interesting topics about this title, this presentation. And let's go and we will begin. First of all, please, I would like to introduce myself. I'm Dr. Castillo from Instituto Bernabeu. I'm a senior specialist in the assisted reproductive medical field. I'm a member of the European Society of Reproductive Medicine and Embryology. And from 3 years now, I have accepted a position as an associate editor for the Human Reproduction Journal. And of course, I will be in charge of giving you this lecture. Well, these are the contents of our presentation. We will do a brief introduction, talking about the prevalence, definition, and terminology of the recurrent pregnancy losses. After that, we will talk about the first visit, in which we will address the risk factors and health behavior. After that, we will talk about the etiology of this condition. Next, we will talk about the investigations and treatment in recurrent pregnancy losses. And finally, we will go for the Q&A section. Well, in our center, we will try to guide our treatment based on the best medical evidence. And for this presentation, I have based on this current literature. First of all, these recently published guidelines, November this year, the last year, about recurring pregnancy loss. We have also took a look at what is happening overseas in this by guiding ourselves from this committee opinion by the American Society of Reproductive Medicine published back in 2012. And finally, I would like to highlight this very recent presentation, March this year, published in Human Reproduction Journal from Popescu et al., in which 100 patients having recurrent pregnancy losses were or underwent a very comprehensive evaluation. And I would say that this will be a very interesting paper to talk about. So, if we wanted to put it in simple terms, pregnancy requires little more than implantation of a developmentally competent embryo into a receptive endometrium. Well, it seems to be very simple. However, in the human species, clinically recognized pregnancy loss is a very common condition, happening in approximately 15 to 25% of pregnancies. The majority of these sporadic losses before week 10 of gestation are the result of random numeric chromosome errors within the embryo. This means are due to embryonic factors. On the other hand, recurrent pregnancy loss is a greatly distressing problem that happens in around 4% of reproductive age couples. With regards to the definition and terminology, this means what are we talking about when we talk about recurrent pregnancy losses? Well, a diagnosis of recurrent pregnancy loss could be considered after the loss of two or more pregnancies. After the loss of two or more pregnancies. Pregnancy in the definition is confirmed at least by either serum or urine beta-ACG, this means the hormone of pregnancy. This includes non-visualized pregnancy losses, the so-called biochemical pregnancy losses. The term will include all pregnancy losses from the time of conception until 24 weeks of gestation and will include both spontaneous as well as assisted reproductive technique of pregnancies. And we will finally leave the recurrent miscarriage term in order to describe cases where all the pregnancy losses have been confirmed as intrauterine miscarriages. On the
Dr.
other hand,
Castillo, can I interrupt for a second?
sorry.
I just wanted to turn on the chat Q&A. I just wanted to enable it. Okay,
Yeah.
and we can continue. Sorry for that.
Okay.
Okay.
It's okay. It's okay. It's okay. Well, I was saying that in terms of the definition, ectopic and molar pregnancies, being molar pregnancies, abnormal pregnancies because of placental abnormalities, should not be included in the definition. Again, implantation failure will also be excluded from this definition. So now let's talk about the first consultation and the risk factors. Well, by definition, we will see the repetitive pregnancy losses patients after the second miscarriage. During this first consultation, we should do throughout a complete medical, obstetric, and family history, addressing lifestyles of both the male as well as the female partner. Factors as the age, previous pregnancy history, previous investigations, and other medical conditions that may be associated with recurrent pregnancy losses, including thrombophilia, diabetes, and the polycystic ovarian syndrome, should be addressed. In terms of prognosis, the maternal age and the number of previous miscarriages will be of the utmost importance. However, perhaps the most important part in this first visit will be to address the psychological impact of RPL. We should remember that we should take into account that pregnancy loss is a significant negative life event, and the repetitive nature of this condition may intensify the grief experience. Additionally, and although studies have mostly focused on women, we should not forget also the psychological impact in the male partner. And according to the guidelines, there is an urgent need for studies addressing on the emotional impact of RPL also on men. Finally, clinicians should take the psychological needs of couples facing with RPL. This means that during this first consultation, we should provide enough time in order to provide a sensitive as well as complete information, to have good listening skills, and to try to respect the feelings of these patients. And finally, we will try to provide information in a clear and sensitive language. During this first consultation, we will address the risk factors, very, very important topic. Women should be sensitively informed that the risk of pregnancy loss is the lowest in ladies below 35 years, and that this risk will increase rapidly after the age of 40. Okay, this should be very, very well clarified in this first consultation. In terms of stress, stress has been associated with RPL, but couples should be informed that there is no conclusive evidence that the stress is per se a direct cause of pregnancy loss. With regards to occupational or environmental exposure, exposure to environmental factors seems to be associated with an increased risk of pregnancy loss. However, according to the guidelines, there are insufficient data to recommend protection against a certain factor in patients with RPL. Of course, as a general rule, every pregnant lady should avoid hazardous environments. With regards to chronic endometritis defines a long-standing inflammation of the endometrium. Some early studies suggested a high prevalence of chronic endometritis in patients with RPL. However, according to the guidelines, further research is needed Before screening, women for endometriosis can be routinely recommended. Additionally, during this first consultation, we should address the health behavior modification. This is crucial. In terms of smoking, smoking has been associated with an adverse obstetric as well as neonatal negative outcomes. And couples with RPL should be informed that the smoking could have a negative impact on their chances of a successful live birth. Therefore, complete cessation of smoking is strongly recommended. With regards to exercise, according to the guidelines, there are no studies investigating the impact of exercise on the chances of a successful live birth in this subset of patients. Of course, a moderate degree of exercise is recommended during pregnancy. However, high-intensity exercise will not be recommended. With regards to the body mass index, couples with RPL should be informed that maternal obesity as well as underweight is associated with obstetric complications, and these factors could have a negative impact on their chances of a successful live birth. With regards to the caffeine and alcohol intake, it is unclear whether caffeine intake is a risk factor for RPL. On the other hand, excessive alcohol consumption is a very possible risk factor for recurring pregnancy loss. So, patients should be advised to limit caffeine as well as alcohol consumption. So, after this first consultation, we will try to address the etiology of the recurring pregnancy loss. From a clinical perspective, miscarriage, whether sporadic or recurrent, could be attributed either to chromosomal or other developmental abnormalities in the embryo or to uterine factors. So to put it in simple words, the problem could be either in the embryo or in the uterus. So now let's talk first of all about the embryonic factors associated to RPL. After fertilization, the embryo may have some cytogenetic abnormalities, some embryonic abnormalities, chromosomic abnormalities. This could be, essentially speaking, of two types. This could be cytogenetic abnormalities, the so-called aneuploidies, or this could be structural chromosomal abnormalities. Let's talk about the first type, cytogenetic abnormalities in the pregnancy loss. When we examine the products of conception, it's estimated that around percent of the products of conception in early pregnancy losses are associated with sporadic chromosomal abnormalities, primarily trisomies that are in part age-related. I will not get into detail about this topic because I'm aware that in a previous webinar this has been already covered, but to put it in simple words, if an aneuploid egg, this means having an abnormal number of chromosomes, in this case having 3 chromosomes instead of 2, is fertilized by a normal sperm having a normal number of chromosomes, an aneuploid embryo could be developed. Perhaps the most unknown condition is the so-called Down's syndrome, the trisomy 21. In this case, on the position 21, instead of being 2 chromosomes, there are 3 chromosomes. And of course, this is a very, very known condition, and this could be the cause of early pregnancy losses. And this is very important also because of this. You can see in this graphic the probability of achieving a live birth in comparison with the age. And as you can see here, with the advanced maternal age, there is a decline in the chances of a successful live birth. Conversely, there is an increased rate of the miscarriage rate, especially because of an increased rate of aneuploidy within the oocytes. We should be aware that from 37 years old onwards, there is an abrupt decline in the number, but also in the quality of the available eggs that may explain all these findings. And finally, this is very important because according to recent data, this data is coming from Eurostat 2015, there is a steady increase in the mean age of women at birth of first child, approaching 30 years now. And more or less the same is happening overseas. This is data coming from the States. in which you can see in this graphic that there is a still increase in the age of women at birth of their first child. So this seems to be a worldwide phenomenon, at least in Western societies. But this is not the only problem that an embryo may have. We can also find what we call the structural chromosomal abnormalities. In around 2 to 5% of couples facing RPL, balanced translocation could be observed. Let's go a little bit more into detail about this. It's not so easy to explain, but in brief, a translocation describes when a portion of one chromosome is transferred to another chromosome, as you can see in this graphic. Translocations then can be balanced or unbalanced, depending upon whether there is a net gain or loss of genetic material. This kind of chromosomal translocation could be present in either parent. So the cells of either parent may have this chromosomal translocation. So when gametes, eggs or sperm, are generated, there could be balanced gametes or unbalanced gametes. And an unbalanced gamete may generate an abnormal embryo, explaining the miscarriages. So parental karyotyping and genetic counseling is very important when a structural genetic factor is identified in the embryo as a cause of RPL. What about the male factors? Is it possible that male factors may explain these negative outcomes? Well, sperm aneuploidy and DNA fragmentation have been studied in couples with RPL. Sperm fragmentation, for example, defines the DNA damage within the spermatozoa. The main cause of DNA damage is oxidative stress, and this seems to be exacerbated by unhealthy habits, smoking, obesity, excessive exercise. Recent studies have reported a significantly increased sperm DNA fragmentation in couples facing RPL. So finally, according to the guidelines, assessing a sperm DNA fragmentation in couples with RPL could be considered and recommended. With regards to spermaploidy, to put it in simple terms, defines chromosomic abnormalities within the sperm. Some early studies suggested an increased rate of sex chromosome disomies in the sperm from the male partner in couples facing RPL. However, further cytogenetic analysis of the products of this conception did not reveal an increased rate of this condition. So, finally, according to the guidelines, routine testing for spermaploidy, for example, by doing the so-called FISH test, is not recommended. So, finally, if we detect an embryonic factor as a cause of RPL, what are the available treatment options? Well, first of all, we can consider the embryo biopsy as a technique. The embryo biopsy involves the reach of these embryos until the blastocyst stage, and at this moment, what we do is to take out a cluster of cells from the embryo. The cells are then analyzed from the genetic point of view, and as soon as we confirm that we have a genetically normal embryo, then we can prepare them to mature in order to put back this embryo. Of course, the other option is still there, to change the gametes. Secondly, what happens if the problem is not in the embryo? If the problem is not within the embryo, of course, should be in the uterus, and we will be talking about the uterine factors. Here, we will describe briefly several topics. The first topic to screen is the thrombophilia condition. Thrombophilia is a condition that predisposes women to venous thromboembolism. Thrombophilia can be further divided into hereditary thrombophilia. This is genetic causes predisposing patients to venous thromboembolism. Additionally, these conditions are presumed to be a causal factor for RPL. This involves the factor V laden and proton gene mutations, protein C, protein S, and antithrombin deficiencies, and the MTFHR mutations. Although an association between hereditary thrombophilia and fetal loss has been suggested, prospective cohort studies have failed to confirm this previous early finding. So, according to the guidelines, routine testing of women with RPL for inherited thrombophilia is not currently recommended. On the other hand, we have the so-called acquired thrombophilia. Acquired thrombophilia refers to the antiphospholipid syndrome. Antiphospholipid syndrome involves the persistent presence of antiphospholipid antibodies and is clinically related to vascular thrombosis and pregnancy complications, including pregnancy losses. The acquired thrombophilia includes the lupus anticoagulant, anticardiolipin, and beta-2 glycoprotein antibodies. According to the guidelines, screening for acquired thrombophilia is recommended in patients facing RPL. And in case of this finding, the administration of low-dose aspirin as well as heparin is recommended. Of course, very important, the uterine anatomic factors. Of course, any anatomic distortion may preclude a correct embryo implantation or embryo development. Congenital uterine abnormalities have been associated with several obstetric complications, including pregnancy losses. So, according to the guidelines, all women with RPL should have an assessment of the uterine anatomy, and the preferred technique to evaluate the uterus should be the transvaginal 3D ultrasonographic scan. This is, for example, a very nice picture of a 3D evaluation of the uterus showing this triangle shape of the endometrial cavity, and this should be the normal shape of the cavity. The 3D scan is recommended because it is able to discriminate between this condition, the septate uterus, and other potentially relevant congenital tract malformations. And this is important because septate uterus is the only condition amenable to be surgically corrected. So let's talk a little bit more about the septate uterus. Septate uterus defines the presence of an indentation, as you can see in the image, indentation in the fundal uterine cavity. After a 3D scan confirmation, a hysteroscopic septum resection should be considered. However, according to the guidelines, the true beneficial effect should be further evaluated in the context of trials, including women with repetitive pregnancy losses and septate uterus. However, these congenital malformations are not the only finding. We can have several other anatomic factors, for example, the presence of intrauterine adhesions. Adhesions are frequently detected in women having repetitive pregnancy losses. And although hysteroscopic surgical correction should be considered, according to the guidelines, there is still insufficient evidence of benefit of surgical removal of intrauterine adhesions for pregnancy outcome. With regards to uterine fibers, we should remember that uterine fibers are defined as benign uterine tumors. With regards to the uterine fibers in the context of RPL, there are no studies on the effect on the treatment of these fibroids in this subset of patients. According to the guidelines, there is insufficient evidence supporting the removal of these fibroids. However, in our opinion, surgical correction should be considered in the case of submucous or intramural fibers distorting the uterine cavity. We will go into detail about this point in the question and answer section. Finally, we can have also uterine polyps as a finding. Uterine polyps are benign endometrial tumors. Endometrial polyps are found usually in women with RPL. However, again, there is insufficient evidence according to the guidelines supporting a routine hysteroscopic removal of these polyps in patients having RPL. Perhaps surgical excision should be recommended in the presence of big polyps, let's say more or greater than 1 centimeter. As a general rule, we recommend surgical correction of any significant uterine cavity defect. Now let's talk about the hormonal and metabolic factors presumably related with RPL. And the most important, I would say, are the thyroid abnormalities. Thyroid hormones are essential for fetal development. Additionally, thyroid hormone disorders are associated with disturbed folliculogenesis, spermatogenesis, fertilization, embryogenesis, supporting an important role of this hormone in subfertility and pregnancy losses. According to several studies, a clear association between subclinical hypothyroidism and autoimmunity and RPL has been found. So the guidelines is consider testing for thyroid function as recommended in this subset of patients. And in case of any finding, these patients should be treated using levothyroxine. With regards to other hormonal and metabolic factors, for example, with regards to the insulin metabolism, we should clarify that an uncontrolled diabetes is, of course, associated with increased rate of pregnancy loss. However, well-controlled diabetes is not. Again, in the guidelines, several markers for insulin metabolism were assessed in women with RPL. However, the guidelines concludes that there is not enough evidence in order to recommend routinary testing for these insulin metabolism markers in women with RPL. With regards to prolactin, prolactin is a hormone with an important role in ovulation, maintaining the corpus luteum function, and progesterone secretion. However, evidence is inconsistent on its association with RPL. Perhaps we can recommend testing only in the presence of additional clinical symptoms associated with increased prolactin levels, for example, oligo or amenorrhea. And if something positive is found, perhaps the treatment with bromocriptine or carbergoline can be considered. With regards to vitamin D, we know that vitamin D has a significant role almost in every organ metabolism. And vitamin has also been studied extensively in relation to obstetric complications. However, the association between vitamin D deficiency and pregnancy loss is very, very less consistent. Finally, the guidelines conclude that there is no enough evidence in order to recommend testing of vitamin D routinely in patients with RPL. Now let's talk about this very controversial topic, the immunological screening. Perhaps we may begin by saying that a normally functioning immunologic system is essential to sustain a pregnancy. And, at least in theory, an overreacting quotation marks immunologic system may preclude a correct embryo implantation or embryo development. Several immunological markers have been studied so far. However, perhaps the most renowned or important ones are the natural killer cell testing, the NK cell. So let's describe NK cells. NK cells are a subtype of specialized lymphocytes, and these cells play a critical role in the immune response. Studies analyzing NK cells in the peripheral blood suggest but a weak association with RPL. The investigations of these NK cells can be divided into testing of NK cells on the peripheral blood or testing the NK cells in pre-pregnancy endometrial biopsies. However, significant technical challenges remain because, for example, frequencies of NK cell subsets between endometrium and peripheral blood are extremely different, and cell numbers fluctuate hugely in the menstrual cycle. Additionally, lack of consensus about ranges of normal values and lack of standardization in the measure of NK cell persists. So, because of these conditions, according to the guidelines, there is still insufficient evidence to recommend routinary NK cell testing in either blood or endometrial sample in women facing RPL. A brief comment about the so-called non-conventional treatments for RPL. Chinese herbal treatment, acupuncture, homeopathy, antioxidant. Well, in brief, according to the guidelines, these treatments cannot be recommended to improve the pregnancy outcome in women facing RPL. Now let's talk about the next point, investigations and treatment, and a little bit of the prognosis of this clinical case. We will try to propose an algorithm for evaluation and treatment. Well, this flow chart is based on this recent publication, remember March this year by Popescu et al. Just to recall, in this publication, 100 of patients having repetitive pregnancy losses underwent a comprehensive study, including the chromosomal analysis of the products of conception and additional uterine testing according to the medical evidence. So, by definition, we will see our patients after the second miscarriage. We will focus the first visit. We will address the risk factors, health behavior, psychological counseling. And according to Popescu, if possible, we should first of all analyze the products of conception from this genetic point of view by doing a chromosome analysis. If the result shows an euploid embryo, remember this is basically related to the maternal age, we should consider IVF with PGS or PGTA as a treatment option. Reception of donated oocytes will be another option, and also expectant management. On the other hand, if we find unbalanced chromosomal translocation as the embryonic etiology of this miscarriage, of course parental karyotypes are mandatory. In this case, we should consider IVF with PGD versus expectant management. Also, we have the option of the gamete donation. However, the products of conception could be also euploid. This means completely normal. So in this case, of course, we should undergo this extensive panel screening for acquired thrombophilia condition, a complete 3D scan evaluation of the uterus to rule out additional uterine factors, screening for thyroid abnormalities, and although controversial, we can also include the immunologic testing. Well, the previous slides will show a very dark scenario. However, the prognosis is not so bad in these patients. Here we have, for example, two graphics. In this first graphic, we are comparing the probability of achieving a successful live birth according to the age of the patients. And as you can see, the younger the patient, the higher the probability of achieving a successful live birth after the first consultation. Of course, these chances, these expectations will be lower with advanced maternal age. The second graphic shows the probability of achieving a live birth in comparison or taking into account the number of previous miscarriages. And as you can see, even with 3 miscarriages, the prognosis is still good. However, this becomes lower after 6 or more miscarriages. In brief, age and the previous number of miscarriages are very important in terms of prognosis, age being slightly more significant than the previous number of miscarriages. In this section, I will try to answer some questions that I saw on the website. For example, this first question, why do recurrent miscarriages happen? What are the reasons for early miscarriage? What are the causes of recurrent miscarriage at 6 weeks? To be concise, in the very vast majority of cases, the problem relies within the embryo. For example, this publication by Philip in 2003 observed or showed that fetal malformations were observed in up to 85% of cases presenting with early pregnancy miscarriage, early pregnancy losses. This same study also demonstrated that the very vast majority of these abnormalities were also or had also an abnormal karyotype. This means were genetically abnormal. So in brief, the main reason for early miscarriage is an embryonic factor. And what are the causes of a recurrent miscarriage after a successful live birth? So here we will base our answer in the publication by Popescu. Remember, in this publication, the authors underwent a comprehensive analysis of 100 patients having recurrent miscarriages, and they were able to find a definite or probable cause of recurrent pregnancy loss in the very vast majority. 95% of these cases had at least a putative etiology. In the very vast majority of cases, 65%, the problem was within the embryo. And 45% of cases also showed some uterine abnormalities, including anatomical abnormalities, thrombogenic conditions, endocrine abnormalities, and abnormal parental karyotyping. Another question, can a sperm cause a recurrent miscarriage? Well, there seems to be a moderate body of evidence indicating associations between RPL and poor quality sperm, particularly sperm with elevated DNA fragmentation. And this association seems to be independent of female factors. Since there is also clear evidence that this sperm DNA damage is caused by unhealthy lifestyles, such as smoking, obesity, and excessive exercise, clinicians could make couples aware of this risk. This means that addressing this unhealthy lifestyle or to try to promote healthy lifestyle is essential, especially during the first consultation. Finally, according to the guidelines, assessing sperm DNA fragmentation in couples with RPL can be considered for explanatory purposes based on indirect evidence. Let's talk a little bit about fibroids. Can fibroids cause recurrent miscarriages? Remember that fibroids is one of the most prevalent pathologies. It's one of the most prevalent tumors in the gynecological area. So in our opinion, it's very important the location of the fibroids. For example, here in this image, you can see what is called a subserous fibroid. This means fibroids growing up but to the outer surface of the uterus. These fibroids are not relevant for fertility purposes, and these are not usually treated in patients having repetitive miscarriage because there is no impact from these fibroids. On the other hand, here in this image, you can see a nice example of an intramural fibroid, but impacting and distorting the uterine cavity. And also, you can see here a very good example of a submucous fibroid. In our opinion, these fibroids distorting the uterine cavity, in these fibroids, we should consider the surgical removal of these fibroids. Can an infection cause recurrent miscarriage? Well, several pathogens have been identified in patients having sporadic miscarriages. However, so far there are no convincing data that infections can cause recurrent pregnancy losses. Therefore, and according to the guidelines, and based on very inconsistent evidence, there are no clear indications for routine early screening of these organisms in patients facing RPL. Is karyotype testing beneficial? That's another very frequent question. Well, if we take a look at the study by Popescu et al., remember, in this study, only 4% of patients had an abnormal karyotype. In brief, this means that karyotyping is perhaps of limited value. Parental karyotyping, although not routinely recommended in couples with RPL according to the guidelines, could be carried out after an individual assessment of risk, for example, the presence of previous translocations in other members of the family. Another question, is IVF with PGD recommended? Again, remember, according to the publication by Popescu, the very vast majority of these cases were embryonic, had embryonic factors as etiology. So we consider that there is a place for IVF with PGD in order to deal with this topic. However, according to the guidelines, there is still limited evidence suggesting pre-implantation genetic testing for this subset of patients. However, we should underline that the studies included in these guidelines supporting this conclusion are old-fashioned studies using old-fashioned, for example, methods of analysis, including the fish analysis, which is not longer used, at least in our center, in which we use more state-of-the-art platforms. Additionally, the vast majority of these old studies included day +3 embryo biopsies. This is not longer done, at least in our center, because we exclusively proceed with a biopsy at the blastocyst stage of the embryo. So it's very likely that perhaps this recommendation will change in the near future. The final questions: recurrent pregnancy loss and spontaneous miscarriages are donor eggs a cure? Well, I would say that the answer is yes, especially if the factor is embryonic related to the female age. And this is the last slide of my presentation. I would like to take the opportunity to thank to all my teammates in Instituto Bernabeu for helping me every day to provide the best standard of care for our patients, especially patients facing repetitive pregnancy losses. Of course, I will be more than happy to answer any question that you may have. Thank you so much.
Thank you very much, Dr. Castillo. So I think we can move on to questions and answer session. Okay, the questions will appear on the screen and I will read them and doctor can answer them. Let's start. Yes, we can see you, doctor. Fantastic.
Hello.
Would PGS with your own eggs also be a possible cure for recurrent miscarriage? Question from Christine.
Very good question, Christine. Well, as we explained in our presentation, yes, we believe that is a technique to consider. If the embryo is a factor, at least from the assisted reproductive medical point of view, the only way to be completely sure that we will be transferring only genetically normal embryos is by doing the embryo biopsy procedure. In our center, we have so far a 3-year experience doing this procedure at the blastocyst stage of the embryo. We have biopsied more than 2,000 embryos so far. So this is a very well established and robust platform in our center. However, we should also clarify that this is a very potent technique, this is a very specialized technique, but it's essentially a diagnostic technique. This means this technique will tell me whether there is or no genetically normal embryos. However, this technique cannot turn a bad embryo into a good one. And of course, patients should be aware of this.
Okay, thank you. Next question. Again from the same patient. At 40 years of age, after 2 early miscarriages and 2 second trimester terminations due to trisomies, all naturally conceived. Okay, so this is the extra information to the previous question.
Well, the answer is the same, of course.
Of course, okay, thank you. Question from Emma. I am 45 and have just had my first trimester miscarriage. The second was a chromosome abnormality. I had abortion and DNC last Tuesday and now realize I need to consider donor eggs. How long do I need to wait before receiving donor egg treatment?
Very good question. Of course, in this specific clinical case, with all this information, of course, I must support your decision, Emma, in proceeding with egg donation. For this specific clinical case, of course, is the treatment option. Of course, after an DNC, in our opinion, you should wait at least for 2 natural periods before embarking on any assisted reproductive technique. So, in brief, a couple of months.
Couple of months. Thank you. Next question. I'm 41 years old. I have had 1 ectopic, 1 miscarriage natural, and 2 further miscarriages via IVF. We have had PGS 2 rounds. We weren't able to do PGS due to poor egg quality of the blastocysts. I have PCOC and always get blastocysts, but no success. Then on our last I think pregnancy, we had 1 abnormal, 1 no result. I have been diagnosed with NK killer cells via blood test. We now want to move to donor treatment. Would you recommend any further tests?
That's a very nice question again, Laura. Thank you so much for describing in detail your clinical case, your previous attempts. Well, what can I tell you? Based on the information it seems to be that there is an embryonic cause behind of these failures, and basically this could be associated to the advanced maternal age. As we expose, as we presented in the lecture, this is a very important factor to consider, the age of the pregnant, of the lady. If we are inferring that this is the most plausible cause, of course, one alternative to consider is to change the gametes, to change the egg in this case. So by giving you younger, healthier eggs, of course, it's very likely that we will finally achieve our goal. With regards to NK cells, as I presented in the lecture, however, there is still inconclusive evidence supporting a routine role of NK cell testing in IVF scenario. Moreover, and additionally, it will be less important if we have identified a more potent, a more clear factor that may easily explain all these failures. So, in my opinion, I would say that for this present clinical case, I would encourage you to go for egg donation without any further testing, because we have a very clear factor that can easily explain all these failures.
Fantastic, thank you. We have some additional information from Laura, sorry, if you wish to add anything. This is the same patient.
Yeah, thank you so much for this additional information about the karyotyping. In the very vast majority of these embryonic abnormalities, karyotyping is normal. Parental karyotyping is normal. If you remember the publication by Popescu, 67% of the cases were explained by embryonic factors, but only 4% of the patients had abnormal karyotypes.
Okay, thank you. Next question. Can
That's a good one.
adenomyosis be cause of concern? Yes.
That's a good one. Okay, I didn't include this in my presentation because, to be honest with you, this was not mentioned in the guidelines, and I don't know exactly why. What I can tell you is that, in my opinion, adenomyosis is an important factor and should be considered. In order to explore, in order to rule out or to confirm adenomyosis, of course, the 3D scan control is mandatory in our opinion, because this will give us a correct diagnosis. It's very accurate in diagnosing adenomyosis. Well, adenomyosis can negatively impact the assisted reproductive technique outcomes, and this negative impact is seen in own gametes IVF, but also in egg donation IVF. If we talk about own eggs IVF, adenomyosis is able to impair implantation rates, to decrease implantation rates, and additionally, it's able to increase the miscarriage rate. If we talk about egg donation, again, there is a very nice publication coming from Spain, exclusively focused on egg donation treatment cycles in patients having adenomyosis, and they clearly showed that these patients can have up to a double increase in the rate of miscarriages. So yes, we consider this as an important topic. Adenomyosis, especially a severe degree of adenomyosis, may negatively impact on the subsequent success of these treatments, including egg donation cycles. And the correct treatment in this case is a prolonged blockage of the ovarian function for at least 3 months before proceeding with the actual treatment cycle.
Thank you very much. Next question. After 4 failed IVFs with own eggs and sperm, we finally tried IVF with donor eggs. First attempt was negative pregnancy. Second attempt was positive but had miscarriage at 5 weeks. I am 43 years old and donor eggs are from a 25-year-old. In total, I have had 3 miscarriages from natural conception and 1 from IVF with donor eggs. I have 1 child through natural conception at 36 years old. Husband has lupus. What tests should we explore at this stage before trying our third IVF with donor eggs?
So thank you so much, Tavi, for for letting us know your clinical case. Of course, I can understand how difficult can be for you facing negative results after negative results. Well, of course, in this specific clinical case, I would recommend to take a break, to stop for a while, and to test for additional putative uterine factors. As I presented in the lecture, of course, in this case, I would explore, for example, for acquired thrombophilia, a 3D scan control in order to rule out anatomic factors, hormonal factors, and perhaps we can also consider, although debatable, the immunological screening. But yes, in this case, I would not recommend to go with further treatment, at least until we have a complete uterine exploration.
Thank you very much. Next question. If I had a miscarriage after IVF with donor eggs program, where should I start again? I'm 42.
Well, it basically will depends on the at week at which week the miscarriage happened, and also it will depend on the procedure underwent in order to, let's say, treat the miscarriage, and of course in the absence of complications. Generally speaking, if there was no any problems during the, let's say, the dilation and curettage, and everything was uneventful, and again I would say that in a couple of months you are able to embark yourself on the next procedure.
Okay, we have some additional info. It was the 7th week of pregnancy, the miscarriage. Okay.
Again, DNC, if a DNC was needed, and if this was an eventful, couple of months.
Okay, thank you. Okay, maybe in the meantime we are waiting for more questions. Maybe a question from me.
Tell me.
I'm interested, like, what is the most common question miscarriage patients ask you? What is the most common problem they face?
The most common problem? Well, of course, I mean, when we treat patients having repetitive pregnancy losses, what they want is answers. What they want are answers, because in the very vast majority of cases, they do not know why are they suffering from this condition. And of course, as I told you in my presentation, it's very important to address also the psychological factors in this very first consultation. Okay, and after that, the idea is to try to offer a very personalized treatment plan, because every patient will be different. Every patient will have their own medical background, familiar background, expectations. So the idea is to clarify this scenario in the first consultation, and to try to offer them a very personalized treatment plan. And at the end of this extensive testing, if possible, to provide them answers, because as soon as we find answers, we may focus on a correct treatment plan. We should also remember that according to this last publication, hopefully this will be possible in up to 95% of cases. So in 95% of cases, we will be able to provide these answers for patients. However, 5% of patients will be a real challenge, because we will not know what is the real etiology behind these losses.
Fantastic, thank you. Okay, we have more questions. What age would you say is the cutoff for IVF with your own eggs?
Well, that's a different question, not directly related with the topic. Of course, every scenario is different, and we should personalize every clinical case. Not every lady has or possesses the same performance or expectations in terms of fertility. However, as a general rule, if we focus specifically in patients coming to IVF clinics, the pregnancy rates after 43 years old are a real challenge.
Okay, thank you. Question from Ava. Do you recommend PGS when using donor eggs for the first time? Partner sperm is okay in this case.
Thank you so much, Ava, for the question. Well, the short answer will be no. Will be no. Of course, again, every case will or should be personalized. But if during this previous testing panel we clearly identify that the problem is age related, of course, in this case, we will move for egg donation without any additional PGD or PGS because the realistic probability of having abnormal embryos in this scenario is rather low, especially if the sperm partner is optimal. So the brief question will be no, there will be no indication of PGD if the clear factor identified is age related.
Thank you. May any genetic problem be involved as my partner's sperm was good and we had oocytes from a donor? Does it happen often? I mean miscarriage after IVF egg donation treatment.
Very good question, Doris. Thank you so much. Well, even in a perfect scenario, let's say egg donation with a normal sperm from the male partner, even after a beautiful pregnancy test, we face early miscarriages, even in egg donation cycles. This is estimated to happen in around 10% of the cycles, almost in every center. And well, we do not know the clear etiology of this condition, but perhaps the question is important. What is, for example, the probability of having a genetically abnormal embryo even after an egg donation treatment cycle? In our center, this is rated in 1 out of 5. This means 1 out of 5 embryos produced by an egg donor may also have some genetic problems.
Okay, thank you very much. Do we have any more questions? If anybody has a question, please type them in the chat section. Also, if you have non-medical questions about the clinic's offer or the logistics, we also accept questions like this. Okay, somebody's typing a question. Let's wait.
Okay, perfect.
Yes. My husband is taking daily medication for lupus. Do you have experience with male lupus patients and the effect on sperm count, motility, etc.? Husband's sperm is not optimal.
Well, thank you so much. This is a very specific question. Well, when we face patients having additional health conditions, in this specific example, lupus, at least in our center, what we try to do is a very multidisciplinary approach. This means to get in touch, if possible, of course, with the physician in charge of the male in order to have a complete record and a current status of the condition. And it's very important to see what medication is receiving for the condition, in this case the male, because there are some medications that may negatively impact on the sperm count. However, some others will not. So we should need to coordinate this with the physician in charge of this specific pathology. On the other hand, we should also take into account that perhaps is not recommended for this specific patient to quit the medication because this may worsen the general condition. And in this case, perhaps we may go for the cycle assuming some risks. But as a general rule, what we will do is to try to get in touch with the physician in charge in order to have a coordinated and personalized approach.
Thank you very much. We have one more question. Can anything be done about reducing the 1 in 5 chance of issues with egg donation you just mentioned?
That's a good question, Ava. Well, no. Remember that this is happening at the genetical level, and we cannot intervene so far at the genetical level. So the quick answer is no. We cannot reduce this frequency, this rate of aneuploids. And this is of course general data. Okay, this is a general rate, average. Perhaps in some subset of egg donors, it will be 1 out of 8, for example, and in other subset, perhaps it will be 1 out of 4. But in average, this is the standard rate in our center, 1 out of 5.
Thank you very much. Question from Emma. How closely do you match donors with recipients? Do you look at photos to match facial features or just general points like hair, eye color?
Well, thank you so much, Eva, for the question. Well, this again is not a direct question related with the topic, but well, in this case, we should follow the Spanish law legislation, and the Spanish law commands us to look for the compatibility between the donor and the recipient, specifically phenotypical features. For example, the color of the eyes, the color of the hair, the skin texture, the blood type. So in our center, what we recommend is, if possible, for the patients to provide us some digital pictures from both the male and the female. These pictures then will be provided to the egg donation department with additional information coming from a form that the couple will fill in containing some other specific characteristics. And well, with all this information, the egg donation department will find the most suitable donor for the recipients. Always clarifying that here in Spain, every gamete donation is completely anonymous in both directions.
Thank you very much. I think we have a question for Raquel, patient coordinator.
Okay.
Okay, so let's maybe go to. Okay. Hello, Raquel.
Hello, good evening, everyone. First of all, I would like to welcome and thank you for the invitation to this webinar, and I would like to thank all attendees for their interest and the trust shown in Dr. Castillo and Instituto Bernabeu. So I'm Raquel Gallego. I'm the patient coordinator at Individualized Care Units International, and I'm available for any questions you may have tonight regarding logistics, services, and other procedures. Thank you.
Okay, thank you. Just a quick question to our patients. Can everybody hear Raquel very well? You can type your answers. If you can hear her, we can. Okay. Raquel, we have one question. If my IVF history and treatments are in German, does staff at IVF clinic is fluent in German?
Yes, yes, we do have international department. All our patients have a patient care assistant assigned, and we do have native German speakers at the clinic as well. Yes. English, Dutch, Russian, Italian, French, almost nine languages at the moment.
Okay, yeah, I can hear some, I can read some comments that it's a bit too silent. Raquel, on your side, if you can speak up or probably maybe put your microphone on higher volume.
Maybe?
I think that's much better. Thank you very much. Okay.
Can you hear me
I think
now?
this is okay. I think it's better. Yes.
Okay, thank you.
I think this is question for you. Is it possible to have a embryo transfer of a blastocyst from Czech to Spain? I'm not sure if the question is not very clear, I think.
I think what maybe he's trying to say that he has frozen embryos at the Czech Republic, and they would like to transfer them to a clinic in Spain.
Or maybe transported.
It all depends
Yes,
if the gametes used to produce those embryos are their own, the couples, if they are donated, depending on the conditions, but it's a very complicated question. It's not medical. It's not. I don't think we have.
Yes, okay. The question was about transport. So it was not transfer, it was about
Yeah,
transport.
is to transport the embryo from one setting, in this case Czech Republic, to Spain. Well, in this case, we will need to coordinate, and the coordination is done between the two centers to take a look at the feasibility. Perhaps, well, Czech Republic is a European Union, right? European Union. If it's within the European Union, perhaps it's feasible. In this case, our well, the coordinator of the lab, of the embryology lab in our center, should coordinate with the chief of the lab from the other center. And after this coordination, we will see whether it is feasible. Perhaps if, as being countries in the European Union, perhaps this is feasible.
Okay. Yes, I think there are cryo shipping companies that do
As well.
this type of transport, of course.
That's also true, yeah.
Yes, exactly. We have had a webinar on that topic as well.
Yeah.
Okay. Now question to Dr. Castillo. Not related to this topic, but do you believe in epigenetics?
Yeah, I was reading the question. Okay, in this typing window. Well, that's a very interesting question. Thank you so much. Well, the short answer is yes. Okay, the short answer is yes. Well, we should remember that we intervene in a very crucial moment of a human being, which is the embryo development. And remember that we try to mimic with what nature is trying to do, but of course we do it in a very artificial environment. Okay, using medication, using cultural medias, using techniques, and I would say that yes, although the topic is not let's say proving, these epigenetics are not proving in humans. There are pretty nice studies coming from, for example, the mouse model, showing that these interventions, procedures such as IVF in the rat model, produces epigenetics in the offspring. So, at least in theory, this is possible. However, as I told you, this hasn't been confirmed in the human model. But we should remember that the first test tube baby, the first baby after assisted reproduction technique, is 40 years old now. Of course, we do not know what may happen, let's say, in 20 years now. It's not proven, at least in theory, this is feasible. It is possible.
Thank you. Question for Raquel. Do you have any affiliation with any clinics in the UK where one can donate semen, and in case if they cannot go to Spain?
Yes, we have partner clinics in the UK where the male partner can provide a sperm sample to freeze the sample there and ship it to a clinic. Yes, no problem. You can contact us at our guidance unit, so we can provide you personalized information regarding this matter, because we work with many clinics in the UK, but it can be done, of course. Yeah.
Okay, so this can be done. Fantastic, thank you. Now question to Dr. Castillo. I'm sorry, the questions now are mixed, but this is the nature of a live event. Questions
it's
just
okay.
come up. It's the beauty of our webinar. Okay,
Yeah.
We had our first IVF with egg donor eggs. I am 43, husband is 40. His sperm's morphology was damaged 99%. We did have, however, 3 good embryos at the end. We have 2 frozen left. Pregnancy tests showed HCG level under 2. What exactly does it mean? It didn't even start to implant. What tests would you recommend before frozen embryo transfer?
Well, again, Erica, thank you so much for providing this information about your clinical case. Well, I will answer first of all the first question. with regards to the ACG level. Of course, everything will depend on every lab. Every lab has their own, let's say, cutoff levels. But generally speaking, levels below 5 are not considered as compatible with implantation. So in practical words, there was no implantation at all. This is a negative pregnancy test. Okay, and the second question is, what can you do in order to improve your outcome? You are describing a condition within the sperm. Okay, a condition within sperm. You are describing that 99% of the morphology was abnormal. This means this spermatozoa had, I don't know, 2 heads, 3 tails, 4 necks. Okay, there was a very, very high degree of abnormal sperm morphology. However, we should remember that in the very vast majority of cases, I don't know if this was the case, we use the ICSI method in these cases, in cases with abnormal sperm morphology. We should remember that if we do ICSI procedure, the biologist team will select the normal embryo. Okay, we are talking about 99%. This is a very high percent, but of a very number of spermatozoa available. This means that even if we have only 1% of normal sperm, I would say that we will be able to find enough spermatozoa in order to proceed with the ICSI method, normal spermatozoa. Okay, so even in egg donation treatment cycle, after the single embryo transfer, we face nice pregnancy expectations. This is around 50% in our center. This means, on the other hand, that 50% of our patients will not become, thank you so much, ICSI. This means, on the other hand, that up to 50% of our patients will not become pregnant in the first attempt. So if during the first evaluation we haven't detected any additional putative factors, I would say that this is a mere reflection of the lack of effectiveness of the technique, which is not, unfortunately, 100%. So at this very moment, I will just give these couple of embryos a try, a chance, and I would say that we have realistic options of a successful outcome in the frozen embryo transfer cycle.
Thank you. We have a couple of more questions for Dr. Castillo.
Go ahead.
What is your age limit for egg donation? I have asked the patient, she means egg donation, egg recipient.
Yeah, she's a recipient, and she wants the range in terms of the age of the egg donor. Well, according to the Spanish law, you mean the limit age of the recipient or the limit age of the egg donor?
I think she means the age limit for a recipient.
For the recipient. Well, there is a consensus among the clinics here in Spain, and we do not proceed with any assisted reproductive technique treatment over 50 years old.
Okay, so up to 50.
Up to 50.
Can going through perimenopause affect receiving egg donation treatment?
Very good question. Thank you so much, Ava. Well, in brief, no. I mean, perimenopause will not affect the outcome. In fact, this is a very, very common clinical presentation, at least in our center, and this is not relevant for the success rate. We may have the same pregnancy expectations even in women having the menopause.
Thank you. Do we have any more questions? Okay, I think we can accept a few more questions if we have any. Probably 10-15 minutes more, yes, and we will be slowly finishing again if we have questions.
Perhaps I will expand on this last question, and the reason for having the same success rate is that because we will manage the cycle. This means we will use medication artificially cycles. We will induce a correct growing of the endometrial lining by using this medication. This means we are controlling the cycle, not the recipient, let's say. This is why It doesn't matter whether she's on the menopause or not.
Thank you. Question from Erica. How much longer should we wait after this first IVF and the next FET?
From the strictly medical point of view, you can proceed straight away with the bleeding after stopping the medication after the negative pregnancy test. This is possible without any impact on the subsequent outcome. Of course, if for any reason you want to delay the procedure, the pregnancy expectations again will be exactly the same. From the medical point of view, you can go straight away, and this is mimicking what happens in nature, because nature prepares the uterus every month in order to receive an embryo.
Thank you. Two people are typing questions. Let's wait a moment.
Great.
Four people are typing.
Let's wait.
Yes, we have a question from Doris. Would you recommend to collect more embryos from 2-3 IVF egg-donation cycles to do the PGS testing?
Well, that's an interesting question. Well, generally speaking, we do not recommend to go for PGS in egg donation treatment cycles. Again, of course, everything will depend on a very, very personalized clinical case. Okay, not every case is the same. Perhaps if we suspect any additional genetic contribution coming from the male, for example, any translocation, of course, in this case, PGD could be indicated. However, as a general rule, we do not recommend PGS in egg donation treatment cycles. Having said this, well, the strategy that Doris is describing is perfectly feasible. This means we can accumulate embryos in order to do PGS, but I would say that this will be limited to very, very specific clinical cases.
Thank you. Question for Raquel. How many times do you need to travel to Spain, and for how long for each visit?
Thank you, Mercy. It depends on the treatment, but for our
Can I ask you to speak up, because I think we have
some problems?
can not hear you. A bit better. Yes, if you speak louder, it will be better. Thank you.
Okay, excellent. It depends on the treatment. We try to obviously make things as easy as possible for our international patients. Having that, we offer our first consultation via Skype or video conferencing, or at the clinic if the patient decides to have this first evaluation of the case with the doctor over a video conference. Then they will only need to travel for the embryo transfer, providing a sperm sample of the donor's egg retrieval day. But if they have the first consultation via Skype, only once. They will only need to travel to Spain once. As I said before, we're available at our guidance units to answer all your questions. You can contact us at any time, and we'll be happy to solve all queries regarding logistics and the procedures and everything.
Okay, thank you. Raquel, could you please send the price list for IVF treatments, different testings such as 3D ultrasounds of uterus? Is it possible you can send it to person interested?
Yes, of course, we can. He can. We'll need the contact details, of course. We'll be happy to receive the request through our web page or at email address, which is guidance@instituteofembryo.com. He can ask all questions regarding the treatment, the course, and everything. We just need an email with name and contact details, like an email address or telephone number, and we'll provide all information in detail and personalized to the needs of the person.
Yes. Okay. Maybe I will add something that all webinar viewers, you can contact us. You can contact me at dorothy@ivfmedia.org, and I will redirect you to Raquel, and I'm sure she will be happy to help you with the price list, and so on. Okay. Is this a question for Dr. Castillo or Raquel? How long does it take on average to arrange an egg donor and start an IVF cycle?
For me, either of us, right?
Okay. Okay, so Victoria, feel free to email me and we will definitely find the answer to your question.
No, we have the answer. What I meant is we both probably have the answer to this question.
Okay, so
from the first consultation until the embryo transfer on an egg donation cycle, it could take a month and a half, approximately to 2 months.
2 to 3 months, more or less. 2 to 3 months.
It all depends.
Well, of course, everything will depend on the clinical case, but I mean, as a general rule, remember we need some preceptive tests demanded by the Spanish law before embarking on any assisted reproductive technique. For example, we need to complete a wireless screening. We need an updated smear test. For ladies over 40 years old, we recommend a mammography, for example. This means we need some preceptive tests. Let's say that we have all these tests. If we have everything ready, validated, we can do the actual procedure in a couple of months.
Thank you. Question for the doctor. Do you use embryo glue and endometrium scraping?
Scratching, you mean?
Scratching, yes, of course.
Yeah, that's a very good question. Thank you so much, Mercy. Okay, embryo glue. Well, we had, for your information, every Thursday in our center, we have a clinical committee, and also we discuss some relevant topics on the area, and this we do this every Thursday. And 1 month ago, we specifically discussed about embryo glue, and we discussed extensively. Just to define embryo glue is a culture media. Okay, it's a culture media. Of course, the brand name is very provocative, right? This is a glue that will cover the embryo, and this will make the embryo to attach to the endometrium. This is very, very provocative, of course. However, let me tell you that the medical evidence is not consistent. We have some publications supporting the use of embryo glue, showing some increase in the pregnancy expectations. On the other hand, we have some other very good papers as well, not showing that benefit. So I would say that the evidence is inconclusive nowadays. So based on this inconsistency, at least in our center, we provide this information to the patients, okay, information about the medical evidence about this topic, and we can agree on the use of embryo glue. We have, let's say, the culture media in our center, and we can use it, of course, acknowledging that the patient is aware that the medical evidence is conflicted in terms of a true benefit. More or less the same about the scratching procedure. I don't know, 3 years ago, in my personal consultation, we used to do a scratching procedure almost to every patient crossing our door, because there were early publications showing, a significant increase in terms of pregnancy expectations. However, more recent papers have challenged this concept. And in fact, at least in the egg donation scenario, there is a very nice paper published a couple of years ago down here in Spain, showing that at least in egg donation cycles, there is no benefit of a scratching procedure. Hopefully, there are at least two very big randomized clinical trials, one in the Netherlands and one in the UK, addressing this specific topic. We expect these trials will be completed by the end of the following year. Perhaps with that information on the table, we will have enough robust information to properly guide to our patients in order about the true benefit of this procedure. Up to this point, we discussed again the medical evidence, but we are not, let's say, recommended recommending a scratching procedure on a routinely basis.
Thank you. One more question for Dr. Castillo. Do you think it is better to use a proven donor, someone who had a baby themselves or produced a live birth before for a couple?
Yeah, that's another very insightful question, Eva. Well, of course, previous proven fertility, I would say that it's always desirable. It's always a positive point. Previous proven fertility can be achieved or can be confirmed either by previous pregnancies on the egg donor or by previous successful egg donation cycles. However, of course, this is very desirable. Having said this, we should remember that the egg donors are usually very young ladies. In our center, 25 years old in average. So this means they are all young students or young workers. So that sometimes it's difficult to have, let's say, proven own fertility, let's say, a donor, because ladies at this age are not thinking yet about pregnancy. What I can say in brief is that generally speaking, the success rate in egg donors are pretty consistent, independent of the previous fertility status.
Thank you. This is a question about embryo glue and endometrial scratch. Is it an extra cost?
For endometrial scratching is included.
It's included. No. But yes, for embryo glue.
For embryo glue, yes.
Once again, can you please repeat? The embryo glue is
an extra cost for embryo.
Is an extra cost. Okay, and the scratch is included.
Yeah.
Correct. Thank you. Okay, do we have any more questions? If any of the attendees comes up with any questions after the webinar, you can always email me at dorothy@ivfmedia.org or contact us via our contact page or speak to our consultants on live chat, and then we can direct you to the clinic you need to speak to. Okay.
Thank you, Dorothy.
I think we don't have any more questions at the moment. Okay, I can see Emma is typing, so if you don't mind waiting, we can have one or two more questions.
Thank you to the attendees for their kind words.
Thank you very much. It's been a pleasure.
Yes, we are also happy that your answers are helping them understand what is happening with their bodies in treatment. We always prefer to have the questions answered live by doctors. Then after the webinar, I think the attendees feel they can get the right answers.
Is there any more questions, Dorothy?
Not at the moment. Okay, I had the impression that somebody was typing a question. Okay, if you have any more questions to Dr. Castillo, definitely nothing is lost, and we can put you in touch with Instituto Bernabeu, and probably I'm sure that they will be able to help you with the answers. Okay, Dr. Castillo, Raquel, yes, thank you very much for the presentation. Thank you for answering
Thanks to you, Dorothy.
No problem. I know it's a very late hour in Spain. It's 10:30 in the evening. So thank you for your effort, and thank you very much to all our attendees. I know this is a very difficult, sensitive topic, and we appreciate that you are here with us, and we wish you best of luck in your next treatment. Thank you very much.
Thank you. Have a good day
Thank
for
you.
you.
Thank
Take
you.
care. Take care. Goodbye.
Good evening.
Good evening. Good
Good
evening to
night.
you.
Sorry. Good night.